Here.
Oh, yeah, I got it.
Good afternoon. Welcome to the Bessie Smith Culture Center. This is our third Thursday's Black History program. We've had two previous to this one, and this is our third one. And tonight, it's going to be the Minority Health and Health Equity piece. This is a quarterly event that we do with the Mountain City Medical Society. So we're grateful to have them in the house. I'm gonna do a little house cleaning, and then I'm gonna turn it over to Dr. Mass. First, I'd like to thank our sponsors, Erlanger Health System, EPB, Mountain City Medical Society, the Tennessee State Government, and the Tennessee Arts Commission. Okay, so thank you for being here. Hope you get something out of it. Thank all of those out in radio land, TV land, streaming land, whatever land you're in, seeing this particular program. We thank you for being a part of it. And before I turn it over to Dr. Mance, I need to say one other thing. Next week, our series will be February 22nd, and that will be a night with folk art. We will have the Grammy-winning, award-winning person in the form of Dr. Don Flemings. Don Flemings will be here with us and doing folk night and music night, and we also have a black folk art exhibit from the Bessie collection on display next week. So if you can join us next week, please come out again, okay? Thank you again, Dr. Mass.
Good afternoon, everyone. This is an exciting time for us to be here tonight. My name is Cornelius Mance. I'm the president of the Mountain City Medical Society, which is a part of the National Medical Society, which is composed of predominantly of African-American physicians throughout the whole United States. And one of our directives is to deal with health inequity associated with medical care and to promote excellency in this care. Today, we are excited to be able to give a presentation concerning cardiovascular disease. Most of us don't recognize that the #1 killer in America is cardiovascular disease, and basically over 900,000 people dying suddenly. And over 50% of these people who die suddenly do not know they have heart disease until they have sudden death. And so what happened to us is that many times for us, we're not aware or think it could happen to us. We have people who basically in the medical field, doctors, lawyers, nurses, etc., many times will begin to have certain symptoms that is paramount that they have heart disease. But what they do, they say, I have indigestion, they go lay down, and they do not wake up. And so this is happening continuously. Over 900,000 people are dying per year. We are able to have some excellent speakers today. Dr. William Blaylock, a general cardiologist, which I've known for 30 years. 30 years. I almost said 40 years, but he don't want to be that old, okay? But also Dr. Jennifer Mirza, which basically I saw her at the East Ridge Hospital for a long time, and we had great relationships with her taking care of patients. But also we have Dr. Curtis McCoy, which I've known, well, 40 years, almost 40 years, in which basically they all have a love for their patients. And Dr. Blaylock is going to talk about general cardiology. Dr. Mirza is going to talk about how women have diseases that may be different presentation from men, which many times we forget. And Dr. McCoy is going to talk about more of the interventions that we should be doing with cardiovascular disease that can save lives. So at this time, without ado, we want to thank the three panelists who come here today to share with the community. Maybe we can be able to give enlightenment and make people more aware of this disease that they may think they would not have, that they may not have, because this is a disease that's rampant throughout the African American community, but also in the white community also. But we have some people says when some people get a cold, we get pneumonia. And so this time I turn over to Dr. Blaylock.
Thank you, Dr. Mance. I appreciate the invitation to be here and the excellent introduction. So I don't have slides. I don't want this to be a presentation. I want it to be a conversation. So we'll just sit and talk a little bit. Dr. Mance already started out with one of the main things that I would lead in with, which is the number one killer is cardiovascular disease. So when you think of all the other disease processes out there, other causes of death, accidents, violent crime, far more people die every year from cardiovascular disease than those other things. I could give you numbers. Dr. Mance already mentioned over 930 or so million people will be affected by cardiovascular disease. I could give you that number. I could say it is a disease process that has not only implications as far as human capital, but economic capital, over $400 billion a year on cardiovascular disease as direct costs for taking care of patients, prescriptions as patients, equipment for patients, indirect costs such as lost wages, disability. So it's got wide-ranging implications. So I could tell you all of these numbers and we could spend a lot of time talking about that. But what I think may resonate a little better is if I say to you, almost everyone in here, probably everyone in here, has in some way, shape, or form been affected by cardiovascular disease. Cardiovascular disease is heart disease, it is strokes, and we had an excellent presentation from Drs. Mance, Gibson, and Thurman the last go-around for that. It can be peripheral vascular disease, diseases affecting the blood vessels. You may know about people that have aneurysms in their brain or in their chest or in their belly that rupture. So it's got a wide-ranging set of issues that go along with cardiovascular disease. So I could talk to you about all of that, but I could say more precisely, almost everyone here or everyone here has had some brush with that. It could be high blood pressure, it could be a relative that has had a stroke or a heart attack or an aneurysm rupture. So no one escapes it. It's a relentless process that we have treatments for but no cure. So how do we approach this? Well, you're going to hear from two of my esteemed colleagues on some of the things that we can do. It all starts with you and me as the patient and the person and the family member because it has to begin with us. I'm not going to ask you to raise your hands, but I'm going to ask a couple of questions. How many here know your shoe size? No, don't raise your hand. Don't raise your hand. How many know what size pants you wear? How many know what type of gasoline goes in your car? Okay. Now, I'm going to ask another set of questions, and I definitely do not want anybody to raise their hand. How many in here and watching, how many people know their blood pressure? How many people know their cholesterol? How many people know their hemoglobin A1C? Okay, so if you know all these other things, your shoe size, your pant size, what type of gas goes in your car, you should know these things about yourself. You should know these things about your body because these are the things that will most directly affect you and the people you love when it comes to cardiovascular disease. Risk factors that can be modified. Smoking. If you smoke, stop. If you're not active, become more active. And that doesn't mean joining a gym and buying a bunch of fancy, expensive clothes. It may be something as simple as instead of driving around the parking lot 15 minutes looking for a parking spot right at the front of the store, you park where you find one and take that extra walk. The steps will be good for you. It may mean after dinner, instead of going to watch Wheel of Fortune, you get up and you go take a walk around the block. Activity doesn't have to be something that is expensive, but it's something that's easily attained. If you're overweight, lose weight. If you drink, stop drinking. Already talked about smoking. Can't tell you how irritating it is when people come in and they say, I'm short of breath and I have heart problems, and they've got a pack of cigarettes in their shirt pocket. My colleagues here will probably tell you they have had the same experience. So those of you out there that smoke, please don't bring your cigarettes to your cardiologist office, okay? But on a more serious note, this is a disease process that, as I've said, is relentless. So we have to be just as relentless. Now, there are some things that you can't change. You can't change the family you were born into, and some disease processes do have a genetic component. Some people have high cholesterol, and they say, I eat well, I exercise, and my cholesterol is still high. Why is that? Well, that's a genetic thing. Your body is just an overproducer. But that's okay, because we have medications that can help that. So some of the things that we would consider not modifiable, such as the families you were born in, we do still have some treatments for. But the things that can be changed, the lifestyle modifications that can be achieved, that should be your goal. Because at the end of the day, it's all on you. And that's about all I have to say about that. Let my other colleagues take over. This is such a broad topic. We could be here forever, but I don't want to bore anybody. I just want to leave you with the important message that your health begins with you. It's not always as easy to say, just give me a pill or give me a test or do a procedure on me. It has to begin with you. And part of that is knowledge. Part of that is understanding of the disease process itself. And that's what we hope to achieve here tonight. Thank you.
Hello, everybody. Thank you for letting me come here and inviting me tonight. I appreciate it. So Dr. Blaylock asked me to talk about women's cardiovascular health. Luckily, I feel like with the Women's Heart Health Days and months and everything, it's maybe a little bit more out there that women maybe present differently than our male counterparts. Heart disease in women is, as Dr. Blaylock was mentioning and Dr. Mance, that it is just as prevalent in women as it is in women. Back in the day, women were told, no, they don't have heart disease, but now we know that women do have heart disease. The thing is that a lot of times our symptoms are different than our male counterparts. So luckily, I think there's more attention to it nowadays as far as that women don't always have chest pain. Now, women can have chest pain, so I never tell somebody to ignore chest pain if they're having it, but women can have chest pain. But other things that women more often will complain of is extreme fatigue, which is a very hard one to kind of assess because who isn't tired, as far as when they've got a family and they're running a household, they're trying to work and take care of the household and everything. So that one can be one that is harder for people to recognize that, okay, something's not right here. But fatigue is a common one. Shortness of breath is another common one. Nausea, vomiting is another one that people will start having, that women oftentimes will complain of. And yet again, can't ignore that chest pain going along with any of those things is something that we have to pay attention to. With women, we know that there's all these different risk factors, as Dr. Blaylock mentioned, and things that we can control, as he discussed, tobacco use, exercise, keeping a healthy weight, eating a healthy diet. Those are things that are, in theory, in our control. I don't know about weight necessarily. I always feel like it's in my control. But anyway, those things that we say are modifiable risk factors. But women, we have a different set of risk factors that honestly aren't even really talked about as much. So for women, like early menopause, that's actually one of the risk factors that, of course, men don't deal with, of course, and that is a risk factor that can lead to women developing heart disease more likely than their other female counterparts that do not have early menopause. So this is usually defined as by before the age of 40, okay? So if you were to go through surgical menopause, meaning like you had a hysterectomy and your ovaries were taken out, or if you just naturally went into menopause at a very early age, we know that that increases your risk of developing heart disease as we get older. Things like gestational diabetes, we know that that also increases your risk of developing diabetes as we get older, but then also, we've seen that there's an increased risk of development of heart disease in women who had gestational diabetes, even if they maybe don't develop the diabetes themselves later on. Things like gestational hypertension. So when we're pregnant and the blood pressures are having problems, that's another thing that actually will increase your risk of developing heart disease as you get older. So yet again, these are things that, men, and I will say that even as a female cardiologist, those things are not even talked about that much in reality. But those are some of the things that we as women are unique in as far as what we those things will increase our risk of developing heart disease as we age. I think the most important thing that I always try to bring home to my female patients is that you have to be aware that sometimes, not sometimes, we're all different. We're better maybe sometimes, but we're different in how sometimes men will present. Yes, we can have the same symptoms as men when it comes to heart disease, specifically, with chest pain. But the other things that I mentioned, the fatigue, shortness of breath, even nausea, those are things that sometimes are they're kind of looked over because we think something else is causing this. Other things are bringing these symptoms on. The thing that I want to always impress on my patients, females in particular, is to be aware, ask questions. Some of those risk factors that I mentioned, like if you did have hypertension during your pregnancy, if you did have gestational diabetes, if you had early menopause, those are things to keep in the back of your mind of like, okay, do I need to talk to my primary care doc? Do I need to talk to them about some of these symptoms that I'm having? Or is it that you need to go see a heart doctor on your own? Call up us at Erlanger or whichever. All of the practices here in town are phenomenal. But to see if you need to get some testing done to see how healthy your heart is. But yet again, the heart disease affects everybody, but women have traditionally been underrepresented in a lot of the studies too. But luckily, things are changing, and things like this are what hopefully are going to help bring people to, or women specifically, to, okay, I need to be a little bit more aggressive maybe about asking some of these questions of how I can keep my heart healthy, not just heart, but brain health, and all those other types of issues that we can have with our vascular system. But I think that was all I had that I wanted to bring to the table for everybody, and so we'll hand it off to you, Dr. McCoy.
I want to hit on something she said, and that was the symptoms of shortness of breath and tolerance. Over the last few years, that symptom package has really been clear to me that makes a difference. Everybody doesn't have chest pain. Everybody doesn't have it to the jaw, to the left arm, and particularly women. I remember vividly about 8 years ago, we had this situation where one of our church members was coming into the lobby, and all she was complaining of was, Doc, I'm having all she said. She is in her 60s, she's hypertensive, a little bit overweight, has some cholesterol issues. She's my patient. And lo and behold, she said, let me sit down so I could take a rest right here in church before she even gets to wants to go hear the sermon, but she can't get there. And her husband comes up right behind, and he says she's been doing this for the last 3 or 4 hours. So I listened to her, and all of a sudden I said, something's going on here. So we take her, we put her in the car, we take her to Memorial Hospital, and sure enough, she goes into the emergency room, gets an EKG. She's got what we call tombstones in her anterior leads. She's having a heart attack. She is full-blown heart attack. And from right then, we give her some medication, blood thinner, and I take her to the cath lab. And sure enough, one of our arteries is totally occluded. Um, the So I place a stent, and the next step is that she goes back to her room. Sure enough, that symptom has become a major issue, particularly for me, of chasing coronary disease in our population. So yes, women present differently. I'm going to go over here and good evening. There are a lot of things in interventional cardiologists that we could start, but you know, there's a lot that's been going on. I wanted to bring you up to date about some of those things that have been going on that are very, not only peculiar, but they're very interesting as we go forward. As we go, not only go forward in time, but we go forward in age. Not all of us are young chickens anymore. Y'all know that? All of us are young chickens. So I'm going to go through this. This is going to be sort of from a structural heart approach. What has happened? What have you been exposed to? The key here is to make sure that you're aware of these things, that you take it to your family, talk about it, and become, you know, you have any questions about it, let's talk about it tonight so we can open up on it. We have said that these talk to the young man behind there, and he can put these slides on the Bessie Smith website, so you can use this on demand if you want to, okay? Am I going the right way? Okay. So tonight we're going to define structural heart disease, discuss the individual diseases, and the percutaneous treatment. Percutaneous treatment means we're not going to open her chest. We're going to go through the leg potentially and through the radial to repair it. And then at the end, identify a global change. That is the heart team approach. You know, used to the decision making, if you needed a valve, it was between just the interventionalist and maybe the surgeon. Now that goes in a different way, that we have a whole team of people trying to do this together so we come out with the best outcomes. That's so important. TAVR, trans-aortic valve replacement. Trans-aortic valve replacement, meaning we're not going to go through your chest, we're going to go through your groin to use catheters to replace your valve. And the meaningful valve that we replace right now, particularly as TAVR, is the aortic valve. And I'm going to go through that with you. Here's the heart. This is the aortic valve right here. It's calcified, won't open, stiff, causing you shortness of breath, angina, and sometimes passing out. Here's what we used to do, and all we had: open chest, and all these gadgets sitting in. Now we have an opportunity. We could use this valve, open, self-expanding, to replace your valve, and you go home within 48 hours. This is the valve. Now we're planning new repertoire, managing not only patients that are older, in their 80s, who are high risk for open surgery, but lower risk patients. There's improvement of the valve delivery, access site improvement, meaning where we go in, and we protect the brain. We protect the brain by covering the brain so that there are no plaques shifting up into the brain while we're unloading the valve. So that's TAVR, trans-aortic valve replacement. Knowledge is still good. Changes are being made. And most of the time, we, particularly as Afro-Americans, have not really assessed this. So if you have any questions about that later, we'll talk, okay? Valve clip. The valve clip is generally used in a patient's valve that generally is regurgitating or leaking. That's where we use that. The most common place has been used is in the mitral. Okay. So if you regurgitation, if you were having severe regurgitation in the past, the problem would be you would be weakening the left ventricle and developing congestive heart failure. The next step would be to replace the valve. That was the only scenario. Now we could use valve clips to sort of bring, the reason people's valves do this is because the valve coaptation is abnormal. They're not coming together. Once we clip them, we bring that valve coaptation back. Okay? Okay, this is the valve regurgitation back into the left atrium. Okay. This is the valve itself. A lot of stenoses, abnormal, thick, right here. Now we go in, put the clip on. This is the clip. Hardly any regurgitation. And again, that used to only can be fixed by either repairing or particularly opening the chest. Case 2, 77-year-old man, chronic ischemic cardiomyopathy, ejection fraction is the power of the heart, 20%, coronary disease, status post procedure, patient's on ECMO, severe mitral regurgitation. ECMO is on cardiac support. He has severe leaking of his valve. You noticed? The valve is leaking back up into the left atrium. Watch this. This is an angiogram. Procedures are going on right here. If you notice, we clip one side of the valve, 2 clips. There's still a little leak, but minimal. Okay, not as bad as it was. That should help. Parting words for mitral clip, improving our real-world experience. We have low procedural complication rates, improve quality of life, which is the most important thing, and decrease heart failure hospitalizations. Those are the most important outcomes from poor leaking valve that you did not have to go in the chest to do. Just imagine an 80-year-old going into open chest and then recovering. Okay, next step, left atrial appendage obliteration and PFO closure devices. Those are procedural elements that we're using too. A left atrial appendage is located right next to the left atrium. The issue with that is it's really of no use to us, but it's still left there, and it can cause damage. An appendage can have clot developing in it, pretty much primarily through atrial fibrillation. So if you have atrial fibrillation and you still got your left atrial appendage, there is a risk for clotting development. That clotting development could cause stroke, and that's what we're going to go through before we start. Stroke etiology, hemorrhagic and ischemic. Hemorrhagic means bleeding, ischemic means the vessel is just closing. Cryptogenic, 40% in the arch of the aorta. It's at least 30% coming out of the heart, i.e. from that left atrial appendage, about 30%. And atrial fibrillation is one of the most common scenarios in cryptogenic. That's the cardiac etiology. And again, the atheroma, the plaque that come out the aorta, can also lead to that. Okay. Cost. When you have a stroke, there's high cost to not only taking care of you, but in supporting the medical bill too. One of the most debilitating and deadly diseases, direct and indirect cost of stroke, is about $33 billion. 17.9 billion direct medical costs. Between 2012 and 2030, costs are projected to triple from 71 billion to 184 billion. So stroke is a high-cost item. Pre-2015, there was only lifestyle modification, diet, exercise habits, aspirin, statins, antihypertensive, carotid endarterectomy, or carotid artery stenting. Oh yeah, we needed something better, right? We needed more. Atrial fibrillation. Case, 55-year-old Afro-American lady, nursing professor, North Carolina A&T, standing at her board, and she's trying to teach her nursing students. All of a sudden, couldn't talk. All of a sudden, her right arm goes down. Next thing happens, she goes from North Carolina A&T to Moses Cone Hospital. She calls me. The next thing happens at Moses Cone, the interventional radiologist says, your sister has a stroke. She has signs, and subsequently, can I give her TPA, a blood thinner? I told him, go ahead. Next thing we realized, when she goes to the interventional radiology lab, she has a stroke in the right middle cerebral artery. And they pull down the clot with a Mercy device. The next step is she gets better. I arrived the next morning. Guess what? All her problems speaking, all her hemiparesis has gone. She can speak, do better, da-da-da. Well, she talks a lot anyway, so I joked with her. I said, hey, hon, why don't you leave? I talked to the man in front of me. I said, why don't you leave some of that in there so I won't get so bugged by my sister. But she got better. She got better. She was good. The key here was, over time, she had no symptoms. Over time, she could tell us about any symptoms to me or to her physicians. We put a monitor on her twice, and we finally called atrial fibrillation. I'm sure Dr. Mance and Dr. Gibson have suffered from this extended monitoring for people who have stroke and need to be taken care of in terms of deciding whether atrial fibrillation is a part of it. It is a common scenario that we run into. AFib has a 5-fold increase in risk in stroke. 1.5% of those patients, or between 50 and 59, 24% are 80 through 89. Often asymptomatic, 23% detection rate for 30-day monitoring in cryptogenic stroke. So yeah, if you have a stroke, you need a monitor for a while and see if you can improve it. I'm going to skip this. We use DOACs these days, the Eliquis, Pradaxa, Xarelto. Those are the drugs we use most commonly. Coumadin has not gone by the wayside, but it's the cheapest, so it's still on the market. Not yet dominant in the NOAC market. Costly, side effects in these blood thinners. At least 21 to 23% of those patients self-discontinue it at 2 years. Sometimes it requires twice-a-day dosing, and particularly in Eliquis. Bleeding rates are at least 2 to 3.5% per year. So the key here, case 1, 65-year-old man, diabetic hypertension, has AFib, has recurrent GI bleeds, high-risk scores for bleeding. What is our step? Trying to do a left atrial appendix occlusion. This is how we do it. We go across the septum. This is the device. This is the facial appendix. Voila. Voila. We close the left atrial appendage. When this is put in, all of this will clot over. Okay. And so when that's done, that's done through a catheter. It's not done through opening the chest. Once we have that, we're able to stop the blood thinners. Here's a picture, left atrial appendix. Here's the device. There you go. The follow-up, 45-day follow-up with a transesophageal echo. Device was well seated. Stopping anticoagulation. Okay. Case 2, 26-year-old man, posterior cerebral infarcts, no risk factors, 30-day event monitor, negative. This is what he has. This is from birth, a defect here, PFO. A stroke and a PFO, 25% of those have, 25% of the population will have holes in their septum in their heart. 25% of those strokes are cryptogenic. Keep moving. This is hard to see, so I'm going to keep moving here. The patient underwent a occluder into the septum. It was occluded by catheter, not by surgery, and discharged with dual antiplatelet therapy, including aspirin, with a follow-up echo bubble study after occluding that hole in the heart. PFO closure, accepted indications, cryptogenic stroke, monitoring for arrhythmia, patients with recurrent unexplained stroke, and these diagnoses here, scuba divers. The left atrial appendage occlusion is used in the contraindicated patients who cannot get blood thinners. Post-ablation patients, we use that, that's where we use it as well. We can also, it's also a major alternative to doing surgical ligation to the left atrial appendix. PFO, again, does shunt size matter? Atrial field is a long-term side effect in people with migraines. Okay. I'm going to skip this one. Okay. Last but not least, the VSD occluder. That's where the ventricles are separated. The septum can sometimes get a hole in it, and this is how it happens. 80-year-old, white female, hypertensive, coronary disease, diabetic, presents 7 days post-MI. Next things happen, she gets short of breath, minimal chest pain, and gets a new murmur. Sent to Chattanooga, had a right heart catheterization. The PA systolic pressure was 90. That's way higher than normal, way higher. The PA saturation, the oxygen saturation on the right side now is 87%. That means blood is coming from the left side, going over to the right side for some reason. There must be a hole in the heart. Sure enough, there was one. This is the left ventricle. I'll go back to this. And now we put the occluder in. Looks like a butterfly. This is done by catheters. Done by catheters. The occluder occludes the hole in the heart. The patient's numbers go back to normal. The right heart cath goes back to normal at 45. The PA saturation is back down to 76%. Not done with open heart surgery, done by catheters. And she's dancing to the music. Okay? So that's the general interventional thing we've come up with in terms of people who don't have to undergo surgery, that during the beginning of my interventional career, we had to take the surgery, but we got other methods now.
One of the most exciting part of this whole program are questions and answers. And one of the questions that I've been talking about when I began to pass out the flyers, I asked people a simple question. What should you do if you think I'm having a heart attack? Or I'm having chest pain or shortness of breath? So I asked Dr. Blaylock, what should be the first thing that a person should do, and the second thing they should do, and what the third thing they should not do if they think I'm having a heart attack?
Okay. Well, first of all, if you think you're having a heart attack, you need to call 911. Okay? Let me repeat. Call 911. It sounds like a very simple thing, but it really isn't. Sad story, one of my best friends when I was doing my cardiology fellowship in Galveston was in the anesthesiology residency program. His dad was a doctor back in Pennsylvania. He gets a phone call that his dad passed away from a heart attack. What happened was his dad knew he was having a heart attack, drove himself to the hospital, and collapsed and died in the waiting room. So what I tell my patients is, if you think you are having a heart attack, call 911, because they can get to you quickly wherever you are. They can start treatment when they arrive. They can continue that treatment while you're on your way to the hospital. They can radio ahead to the hospital how your status is, and they can be ready for you when you get there. So I tell my patients, call 911. Don't wait for a friend or neighbor to drive you unless that friend or neighbor drives a fully equipped ambulance and they are a medical professional, okay? All right.
Okay. The next question I'll ask Dr. Mira is, why do you die driving yourself to the hospital when you're having a heart attack? Why is it so important to be in the ambulance?
Well, as Dr. Blaylock had said, there are so many options that we have for treatments that can be done immediately when paramedics and EMTs arrive to your home. The biggest thing with a heart attack when you're actively having a heart attack, the reason why you die, one, because God says it's time for you to go, I guess, but the other one is that the oxygen to the heart muscle is blocked off. There's something blocking off the blood flow to the heart muscle. And the most common cause of the heart stopping and you passing away is usually because there's bad heart rhythms that will start happening when the oxygen is not getting to the heart muscle. And that makes the heart, instead of it beating and contracting like it should, it just starts kind of quivering. And when that's doing that, it's not pushing the blood through our system to our brain and our organs, and the blood just starts sitting there. And then that's when we lose consciousness, pass out. And that's usually the main thing that will lead to somebody dying when they're having a heart attack. But yet again, so many things can be taken care of or helped in reducing the risk of those things happening when there are medical professionals that can respond to you immediately. Another one that's important is having aspirin on hand. Taking aspirin if you are thinking you are having a stroke or a heart attack, and get that treatment going for you, because that's another important one. Aspirin's not a blood thinner, but it helps keep the platelets that help form clots from being as sticky to each other, and so it decreases the likelihood of more clot forming inside of that blood vessel where there's a problem.
What kind of aspirin?
So baby aspirin, 81 milligram tablets, has some of the easiest ones. I don't know what y'all tell people, but like you can chew 4 of those, get a 325 milligram dose in you. If you have a regular, the bare aspirin that's a full dose, that's fine too. You can take that. Just the chewable, we chew it up and it gets into your system a little bit faster.
Okay. One of the things, as a neurologist, we see people who comes in with strokes, and one of the things that many times patients will ask, why did I have a stroke? And we basically many times kind of gloss over that the heart is one of those major factors. Sometimes we have strokes and we have patients who have tumors in the heart, or like myxomas, or they can have clots in the heart, or they can have what's called bacterial carditis. Dr. McCoy, how do you deal with those patients who have infections in the heart that's causing many problems that we basically don't realize or why you get this?
Comment on the stemming?
Okay, yeah.
We're really, STEMI, what does that mean? ST elevation, myocardial infarction, acute heart attack. It's really important, as my colleagues have said, for the person to make a decision quickly about getting to the hospital. Why? Time, I want you to remember this, time is muscle. Time is heart muscle, meaning we expect you to be markedly unhelpable, I call it like that, between 6 and 8 hours after you start your chest pain. So what I mean by that is that as you start and you get to the cardiac catheterization lab where we open arteries and put stents in to make sure the blood flow is going down, it's important to get there as fast as you can. There are many protocols at all three hospitals, particularly Erlanger, Memorial, and Park Ridge, whereby there's probably a quality committee. I want you to know that quality committees, a heart team approach to taking care of people who have heart attacks. We measure many things: chest pain to door to EKG, EKG to opening the artery. Those are important measurements whereby we know that you do your best. We know that you do your best. So key is get to the hospital so you can get to the cardiac catheterization suite as fast as possible. Let me say number two. There are two issues associated with distance in what we call STEMI, acute MI. That is, if you're in a rural section, you probably will receive a blood thinner, a powerful blood thinner that will go into your arteries and help bust that clot before you reach the hospital. But if you're in a section like this, where you can get to the ER and to the cath lab quicker, you will go straight to the cath lab. There's a team always on call to come and help you, a catheterization team. So remember that as you speak to your family members. There are teams waiting on you when you get to those labs.
If you have a patient that's already on a blood thinner, but that patient thinks that they're having a heart attack, is that somebody that should take an aspirin?
Yeah. The reason being, like say if you're on Eliquis, we want to make sure not only we take care of the clotting system, that we take care of the platelet system too. So we generally use aspirin still.
Sometimes people need to be on the blood thinners and aspirin even after events. So, yes, we still want you to take aspirin.
Different places.
Yeah.
This condition called Widowmaker used to be, you have less mortality than that. Tell them what the Widowmaker is.
Oh,
Leave that to our interventional cardiologist, because
Yeah.
the best way to treat the widowmaker is what they do with catheters or open heart surgery. So I'm going to leave that to interventional.
we always have called that the proximal LAD, is the major artery that comes in the front of the heart that has a bunch of branches generally. They're usually called diagonals. Okay. But in my mind, that's really not the widowmaker. The left main is in my mind, the widowmaker. The left main is an artery that gives rise, branches, a big LAD and a big circumflex. That is my widowmaker, because that really can take you out because it manages 2/3 of the blood flow to the heart muscle.
So you have extensive cardiac damage.
Absolutely.
Therefore, you have heart failure and you die from it. Anyone else has a question for the cardiologist?
go back over that last description of the Widowmaker?
Okay.
Okay.
Generally, 3 vessels to the heart: circumflex, LAD, and posteriorly, the right coronary artery. The vessel, the one that's called the Widowmaker, is the LAD. It's in the front of the heart. The left main I was telling him about was that the left main bifurcates to the LAD into the circ. As Cornelia said, that's a management of 2/3 of the heart muscle. That can cause major death because of the amount of muscle it affects, as opposed to just in LAD. That makes sense?
And as Dr. McCoy was talking about earlier, the importance of getting to the hospital, calling 911, getting treatment started as soon as possible, is back in the day, we didn't have very good treatments for these issues. This is well before these gentlemen's time. But when we had a blockage in that Widowmaker or the left anterior descending artery, because it supplies so much blood to a large portion of the muscle, as I was talking about earlier, that when there's a blockage there, the blood's not getting to a large portion of the muscle. And so then it increased the risk of scar on the heart, damage to the heart muscle, and then that's when those bad rhythms would happen. And there was a high death rate when people had a blockage there. Yes. Yes.
Ready to go.
Yes. Somebody's on call 24/7, 365 days a year. So there's always somebody available no matter what. And it takes a special breed to do that.
You mentioned about the aspirin, what to do in the case of a possible stroke or heart attack. But what about people who are told to stay on aspirin? Is there a difference, and if so, what, between regular, like 325 versus 81 milligrams, and is there a difference between regular aspirin versus the kind that's coated? Because some people cannot take the regular aspirin and therefore possibly are increasing their chances.
Well, the coated aspirin is going to be better in the vast majority of the cases because that coating is designed to dissolve once it hits the stomach acid and cause less likelihood of stomach irritation. In the acute setting, the setting where you think you are having a heart attack right then, you need the chewable aspirin because that's what's going to get into your bloodstream fastest. But for a maintenance dose, a medication that you will take every day, the coated aspirin is going to be better for most people. Typically, we used to use the 325 milligram dose. Now we know that the 81 milligram dose is just as effective and doesn't have a higher likelihood of bleeding that the 325 milligram dose does. So we want the patients on the least amount of medication that will be effective.
Guidelines have changed over the years too, because used to we would say everybody over a certain age needs to be on an aspirin, whether you've had a heart attack or not. And was it last year, within the last year or two?
First, it was 2018.
Yeah, that we started saying, okay, you know what, not everybody needs to be taking an aspirin if they don't have certain health issues, specifically like heart disease. Now we say, okay, if you've never had a heart attack and you're not in one of the high-risk categories, then taking an aspirin actually won't really benefit you that much. It just increases the risk of bleeding through the GI tract. So that's something to definitely talk about with your doctor. If you're thinking, do I need to be on an aspirin, that's something to be sure to talk with your primary care doc, or if you see a heart doctor, ask them what they feel that you need to be on.
What Dr. Mears is addressing is what we call primary prevention and secondary prevention. Primary prevention is if you take an aspirin a day, it will supposedly keep you from having a heart attack or stroke. We have now found that is not necessarily the case. The benefit does not outweigh the risk. For secondary prevention, people who have had a heart attack, who have had a stroke, who have had a stent without having a heart attack, documented coronary disease, these are the patients that do better with aspirin for what we call secondary prevention.
And I think one of the things I talk about is primary prevention, lifestyle change.
Oh, that was the first thing, absolutely.
And I think when you talk to patients or talk to people about lifestyle change, it kind of floats over their head. because they'll say, I love Krispy Kremes, okay? I love McDonald's. I love Taco Bell. But I think that's one of the things that I think we need to really kind of talk to the community about. Lifestyle change is something that you don't want to do because you're comfortable and you've been doing it all your life, eating saturated fat, eating all the things that basically increase your risk, drinking sodas and Cokes, high sugar content, refined sugars, processed foods, instead of eating. So I think it's one of the things that most people don't really come in contact with. Dr. McCoy?
You know, one of those things is that that we, as physicians, need to bone up on, I think, in terms of every patient that we see has a necessity to change their diet. And every problem that we see, hypertension, coronary disease, has a specific outcome diet that needs to be squared away and talked about. So the key here is this. Remember to ask your questions to your physician about your diet. Generally, when people get to the specialist, we generally see people who have never had a conversation with their doctor about what should they be eating. And we have to go over it. If you care, we have to go over it. So I say that to say this. Be ready to ask about your diet before you leave that office, as well as your medications. I did a talk about a month ago, and these fellows were really gearing up to say, look, I'm not having conversations with my physician. My physician is leaving me in the room not really knowing this and that. Be ready when you go to those visits. Be ready, okay? It's so important. This pandemic has really separated the doctor-patient relationship. Okay? That's what I'm trying to tell you.
I have a question. I heard Dr. Mazzola say that a heart attack had symptoms of trying to beat and getting to the point where it just would be fluttering. And those were very, very close symptoms to AFib. So how can you tell the difference, and are there differences?
So what I was referring to with the fluttering or the abnormal motion of the heart is not the same as AFib or the atrial fibrillation. So it is two separate things. Generally, when that heart starts doing these bad things, that's when you're passing out because the blood's not pushing the way it should. Atrial fibrillation is an issue with the top chambers of the heart, and what I was referring to is the bottom chambers. That's where that widowmaker supplies so much blood to, is the bottom. Those are the main pumpers of the heart that sends all that blood out. The atrial fibrillation is coming from the top chambers, and that is also a same kind of issue of that they're fluttering. It's, instead of squeezing and pushing the blood downstairs to the bottom chambers, they're just sitting there fibrillating or quivering. And people will sometimes feel a fast heartbeat with that. So maybe I said that in the wrong way. I didn't mean that to be like, oh, you're going to feel fluttering with a heart attack. Not necessarily. That's just what can wind up happening when there's not enough blood to the bottom chambers of the heart. But AFib is something where, yes, you will feel palpitations. I'm not saying to ignore palpitations if you are thinking you're having a heart attack too, but it's kind of two separate things.
I understand that you guys had a breakthrough on describing protein buildup in the muscle. And I was trying to figure out how much impact that had on saving lives, because someone said that the protein buildup was not detectable as easily 10 years ago as it is now. So I was trying to figure out what the impact has been on saving lives. And I understand that happens a lot with Afro-American men.
All right, what do I think I know what you're talking about. Left ventricular hypertrophy. thick ventricle, is that what you're talking?
I think they
A
call
thick muscular ventricle?
Or are you specifically referring to a condition known as cardiac amyloidosis?
That's
Oh,
what
okay.
I meant.
Okay, that's the
Yeah.
buildup
That's
of
different.
abnormal proteins in the heart muscle, and you're exactly right. Roughly 10 years ago or so, there wasn't very much we could do for it. We now have medication that is very effective at treating that. We have better ways of diagnosing it, and that is one of the more common causes, aside from coronary artery disease and hypertension, that is one of the more common causes of heart failure.
Yeah. Is there such a thing as broken heart syndrome?
Yes.
I think it's called stress cardiomyopathy, Takotsubo cardiomyopathy. That's the one you're talking about, Larry? Yes, it has to do with a lot of stress. We see patients who come in who have what we call a non-STEMI, generally. Patients who come in with elevated troponins, short of breath. They go to the cath lab, the coronaries are totally normal, and they have a heart that's pumping like this. It's got a name, Takotsubo. We treat them for heart failure, probably about 6 to 8 months. You see it changing, going back to normal. And very common in women. Hey, it's called stress cardiomyopathy, Takotsubo. That's how y'all pronounce it.
Takotsubo, yeah.
As we get older, what do you recommend for those of us who may not have heart disease? Should we start doing any kind of cardiac screening, like EKGs at a certain age and then whatever else? What do we do to check for heart disease or to make sure nothing just pops up?
So yes, definitely. That's where primary care doctors, nurse practitioners, physician's assistants are so important, because they can definitely start the screening process. And oftentimes you're going to be seeing them before you just pop into a heart doctor's office. So definitely having follow-up with them, getting an EKG when it's appropriate, of course. And then there are certain types of heart tests, especially if you're having symptoms, that your primary care doc can even order, as far as like, do you need to have a stress test? Those are things that we don't routinely do. Back in the day, we would sometimes do stress tests more frequently than we do now for screening, but usually it's only now for symptoms. So if you're having chest pain, that's when we will definitely talk about doing things like stress tests, but that's not something that we do just for everybody, who hits a certain age, 55 for men or 65 for women. But EKG, yes. Stress tests are where you're running on the treadmill. 45, I think is
That would be
what they're
reasonable.
saying. Yeah. Okay, so what generally, well, my patients personally, if I do once a year, if they're already in my office, of course, generally if you've come to a heart doctor, then you've got some kind of reason. So once a year is definitely what I will do in the office. Now, from somebody who's like at a primary care office, I think most of the guidelines will say once a year. Like I said, 55 for men is the magical age of increased risk of heart disease in men, and then 65 for women. And so those are the big ones. But the age 40, 45 is where it's good to have an initial EKG performed. Unless if there's other risk factors like diabetes, then we need to be watching closely sooner.
Okay, go ahead. Okay, you kind of touched on part of what I wanted to ask, but I do have two questions. In relation to what you just said, most things start with your primary care doctor with the EKG. But on the other end of prevention, they have prevention for like when women start to get a mammogram, then you have an age for colonoscopy and things like that. So most of the people that come to you already have a heart issue. So I guess my question would be, why wouldn't you have just a regular appointment with just a heart doctor as opposed to having a problem? Or does it always start with the EKG?
Okay,
There's not enough of us to go around.
Yeah, that's a great question. And the issue is a lot of things that can be done by primary care, should be done by primary care. Simple things like an EKG in the office, taking a good history from the patient to tease out what their symptoms may be caused by, a good physical exam. They can even order, as Dr. Mears had said, they can order things like a stress test or an echocardiogram, review those results, which will be read by a cardiologist, and at that point, if the testing is normal, then you can just move on. If it's not normal, at that point, you can get the referral to the cardiologist. But if everyone out there just said, hey, you know what, I think I just want to get my heart checked, as Dr. Mears said, it's not enough of us to go around, and those office spots will be taken up by patients that may not necessarily need to be there, and keep people who really do need to be there out of the loop. So to just say, I want to go to, is that like the wrap it up music at the Oscars and cut my mic? I'll just speak a little louder. So, you know, the people that need to be seen should be able to be seen. And if everyone just said, I want to go be seen to be checked out, that's not a good use of medical resources. Copays are typically higher for specialists, so you don't want to get into a big copay situation if you don't need to.
The other thing too that you kind of touched on is that how do you keep out of our offices? You know, how do you keep from having to see us? The most important things that we've already kind of hammered on this is lifestyle modifications, which is our fancy way of saying eat healthy, exercise, keep a healthy weight, making sure that you are keeping up on like your cholesterol and your blood pressure, you knowing your numbers, as Dr. Blaylock said. Those are the things that all of us can do that doesn't require us having to go to a doctor. Is to help keep us out of the doctor's offices as much as we can, is to eat healthy, exercise, keep yourself moving as much as you can, and then making sure that you're checking your blood pressure, making sure your cholesterol is being checked, making sure your sugar numbers are in a good range.
One of the things that we're kind of afraid of as we get older is how to train your body, most of you, because we got issues with our joints. It's so important that you make a determined effort to learn how to train your body the best way you can, no matter what age you are. It is so important. That's only the way really you can really recover from issues like diabetes, cholesterol issues. Right now, everybody in this place right here looks like they could walk appropriately. But I would recommend you really being intentional about your cardio, really intentional.
My question is, you mentioned about the symptoms that women have, and they're all vague, like the nausea and vomiting and fatigue. At what point should women think, oh, I could be having a heart attack, and go to the emergency room?
So with a heart attack specifically, it's a matter of usually those symptoms worsen tremendously in a rapid manner. Like, you know, we're talking about 30 minutes, an hour, you're declining, like, okay, I'm getting more and more short of breath. When we have blockages starting to form in our heart blood vessels, those are usually kind of slow changes. What I'll ask my patients when they come to me with some of these vague symptoms, like, okay, so 6 months ago, did you feel this way? Like, well, yeah, maybe, but it's worse than it was. Okay, a year ago, did you have these symptoms? Well, no, I wasn't feeling this way a year ago. And then that's, for me, is like the red flag that goes up to say, okay, there's been a worsening that's rapid. Unless if you said you've just been sitting at home, you know, not doing anything, then okay, maybe there would be some short of breath because of deconditioning or being out of shape. But if you're like, I'm doing my normal activities, but I'm not able to do things like I used to, and you're seeing this decline. I've had a lot of women say like, oh, I'm just out of shape, or oh, I'm getting older. But those changes should not happen like that. So if we're seeing a change over the course of a couple of months, 6 months, or a significant change from 1 year to the next, that's when something needs to be addressed and discussed with your docs.
I'd like to thank you all for your dynamic presentation and talk. This is something the community needs.
Thank you all for being here.
Yeah, thank you.
Thank you.
Yeah.
So I congratulate you all for coming out tonight. At this time, we're going to turn it over to the sponsors who basically have a drawing.
So actually, we did a randomization from our kiosk of where you signed in and checked in. So thanks to Liz Appling and Erlanger, we have door prizes for tonight. And so we're going to give away a few door prizes. Yeah, Miss Appling, could you come up here and with us, please? And Miss Appling is also a board member for the Bessie Smith Cultural Center for many years, president of 100 Black Women, and AKA, what else are we going to say?
Too much.
I'm going to let you present. Yes.
Oh, some of them did not sign.
Too late.
No, Dr. Hubbard Shaw, I got y'all's when you came in. So.
Anyone else?
Doris Sudeth. Doris.
Okay. Doris, you just won $100.
No, $50. $50. $50.
Give away $100, but it's $50. So I got $100.
And then also Michelle Pickett. Michelle Pickett. She may have registered online. Okay. Okay, so we'll hold that a second. Marvella Cox. She got the.
You could do one of the couple umbrellas. I'm going to give this one for a special.
Okay. Okay. That's Marvella Cox. Sally McKellar. Sally? She's not here? Online too? Okay. Sharon Grayson.
Sharon Grayson here?
She's right up there.
Okay.
Tamara McCrary. And I will mess this name up. Willietta Hill. Shirley Jackson. She's in the back row, Liz. Al Sutton. Online, okay. Larry Gibson. Mr. Jefferson. He's on the back row. Willie Hubbard. Geraldine Hindley. You got me two more names? Okay. Verlene Middlebrooks. And Fanny Stanton. Tyler. Another one. Actually, two more.
One of my friends knew that I was giving away gifts tonight. She owns a dress shop. And she said, why don't you give this away tonight? So this gift could either get one of the men out of the doghouse who did not give a Valentine's Day gift yesterday, or something really beautiful for one of the ladies to wear to their next formal event. Uh-oh, you got an earring. Isn't that beautiful? So Dr. Mann, so we're going to get you out of the doghouse or what? No, he's never in the doghouse. Okay, so Paula's going to call out the name of the winner.
Sandra Adams.
From Lois's Dress Shop on Highway 58. On Lee Highway. Lee Highway. And this is our last giveaway for tonight. You have two? You have one more? Oh, no, I'm taking that back home. This is my bag. She's going to give my bag away. All right. Okay. The last giveaway.
He says he's pulled all the names. He's pulled them all. But I know it hasn't. It's not pulled them all. Hang on. Send me the randomizer. Jackie Shaw. I tried to give somebody the cooler bag from Erlanger, but Liz is taking it with her. The next Minority Health Series will be on June 6th. And what is that topic?
The topic would be either dementia, Alzheimer's, or men health.
Okay. It's still up in the air what it's going to be, but thank you for coming out tonight. As Eli said, we have 2 more series on Thursday nights this month, so please come back. If you haven't been inside the museum in quite some time, it's changed a lot in the last couple of years, so come back and see us and tour the museum. But thank you to our cardiologists tonight, once again, to Erlanger for supplying door prizes for us, and to EPB, State of Tennessee, and Tennessee Arts Commission, and to the Bessie Smith Cultural Center. So thank you all, and please drive safely.
Thank you.